Everyone, welcome to Pediatric Backgrounds. In the interest of time, as a few more people are getting their lunches, we'll go ahead and get started. I'm Gayatri Jayashankar. I'm one of the general pediatricians with ETSU, and it's really my great pleasure to welcome Dr. Jodi Polaha for our grand rounds today. Before we get started, a couple of housekeeping items. If you all would make sure and call in to the number, sort of not very well seen back there, but it's also on the back table. The number is 423-200-3259, and enter in your event ID, which is 24011. One, that will get you CME credit. If this is the first time you're doing this, you will get a text from CME in the next week or so asking you to identify yourself. But two, even if you don't need CME credit as a student or a resident, please call in using that number, because that's how we identify our number of attendees for grand rounds, and it helps keep the series going. Second little piece of housekeeping item, make sure that you turn in evaluations at the end of the session. Again, this is required for our accreditation, and it's how we can keep grand rounds going and get to hear such awesome talks as you're about to hear from Dr. Polaha. Dr. Polaha, I was looking at her CV briefly. I think is originally an Auburn person, did her clinical psychology from there and her doctorate from there, but then came to us in 2006 from
the University of Nebraska, Omaha.
at
Med
that
Center.
time. And it has just been a complete joy to work with her these last several years. We have had an awesome working relationship in the Department of Pediatrics and the Department of Psychology, where she was initially, and in the last couple of years is now an associate professor with the Department of Family Medicine, and we continue to do a lot of collaborative work. We are proud to tell you that we are sort of path-breaking and one of the leading folks in integrated behavioral health care across the country in pediatric clinics. And I would say a big reason for that is Dr. Polaha. Back in 2008 maybe, she and one of our attendings, Dr. Powers, had written this grant to consider the option of integrated behavioral health in our clinic, and from that has sprung a huge, beautiful relationship. We have had several interns, clinical psychology interns, rotate through our clinic. We have had several of them like it so much that they've come back and joined us as faculty, and really hope to continue this wonderful relationship with her. Her CV reads like a book. Suffice to say, she has written many, many papers, many grants, many case reports, has done a lot of collaborative work with us. So my pleasure to introduce Dr. Polaha. Thank you for doing this for us.
That was so lovely. Can you all hear me? Okay. Put a hand up if you have heard of implementation science before. Okay. And put a hand up if you are currently engaged in or have done plenty of quality improvement projects in your clinic. Okay. I think that answers the questions I wanted to ask, just to see who you all are out there in the audience. And I'm putting on my researcher hat today. I'm in the Department of Family Medicine in the Division of Research, Primary Care Research. So my role is primarily about research and teaching research and facilitating research and driving our capacity for research. So this is really kind of fitting with that goal. I'll talk a little bit more about clinician innovators. Oh, that's a good one. How many of you consider yourself to be clinical innovators? That would be somebody who tries to unlock new ways to do things in whatever clinical setting that you're in.
Probably every one of us every day should be, right?
To some extent, right? On a case-by-case basis, at least, right? What about, like, systematically, though? Like, hey, you know what? This way that we're handling ADHD kids, or this way that we're handling our diabetic patients is not working so well. Let's innovate a new process or strategy for handling this particular population. Anybody consider themselves to be kind of a program developer / innovator in their clinic? Wow, okay, we should be. We'll talk about that. I start almost every one of my talks with my story, and partly because I think it's relevant, and partly because it's the one part of the talk that I know I probably remember most of, because I was there. And so I got my career started in this place, the Monroe Meyer Institute for Genetics and Rehabilitation at the University of Nebraska Medical Center. My appointment was in the Department of Pediatrics there, but my work was in this building with 30 other disciplines focused on kids with developmental disabilities. So we had the ability to provide this very interprofessional model of care in a specialty pediatrics kind of way. And one of the things I did was follow geneticists across the state and look at problems that were coming up in rural places where family physicians or pediatricians were struggling to identify what was going on. Oftentimes the geneticists would render a diagnosis, and there would be a commensurate behavioral or mental health concern, and that's where I would come in. And as I made all these trips around the state, I got familiar with one practice in particular in Hastings, Nebraska, where the pediatricians asked me if I would be willing to come on board in their practice 2 days a week and see patients. And so for 4 years, I drove like on Tuesday morning from Omaha to Hastings, 2.5-hour drive, saw patients all day, spent the night in that Comfort Inn, and then went back to the clinic in the morning, saw a bunch of more patients, and then drove home. And the famous tale that comes from all of that was that after the 4 years I had trained postdoc who wanted to live in Hastings, and we hired that person to work out there full time, and I didn't have to go anymore. It was a bittersweet thing because I loved everyone out there so much, and the Comfort Inn actually threw me a going away party, and we had like this whole like I'm talking like the adult style party in the breakfast buffet area where all the containers of cereal and the waffle maker are. It was real. But that's me back in the day seeing patients in Hastings. And, you know, I think you all have heard parts of this story, or many of you have. You know, the big aha moment for me in that work was how much better my practice was when I was located in pediatrics. And I had a lot of other aha moments, but another big one for me came when I realized that I could be helpful with a systems change. And so pediatricians kept coming to me, what do we do about this ADHD kid? What do you think about this kid? What do you think about that kid? And it didn't take me long to figure out that they didn't feel very comfortable making the diagnosis. They weren't quite sure what their process was. They weren't really sure how to then treat. They were very frustrated by the chronicity of the problem, and this was an area that I had particular expertise in. I had actually done a lot of work in ADHD even as an undergrad, and so I had many years experience in ADHD, and I thought, what if I could help them like system-wide? I mean, to this point, I had been just seeing one patient at a time. Sure, I'll see this kid over here, I'll see that kid over here. What if I, work with you guys on your whole population of ADHD kids? I went and pulled charts from a whole year. And this is what they said they were collecting on every ADHD kid. Were they collecting these data on every ADHD kid? No, they were not collecting these data on. If you look at 1 year, about 90 patients who came in for ADHD assessments, and what you see is they were only actually collecting these data 20 to 40% of the time, and moreover, most of these are not evidence-based strategies. Now this was in like 1999, so we're going back a ways. But the assessment here is like, we really need to implement some evidence-based tools and figure out a way to do it with a lot more integrity so that you guys are actually implementing it. So this is my first time to sit down. This is me, just kidding. This is a stock photo. We did not look that good. My first time to sit down with a team of people, physicians, office management, nursing staff, really kind of coordinating people, the business manager, and sort of go, okay, what would our process look like? And who would do what? And what's feasible? And how long will that take? And so, do they really have time for that? And kind of think through like how it's going to go down. We laid it all out, kind of had this aha moment of like, oh, this is kind of cool. I've been working with all of these people on a patient-by-patient basis, but it's kind of neat to see how we put all the same people in the same room and we can actually resolve we can kind of innovate a whole system for how we're going to deal with one group of people. And so this data, the light blue bar shows 1 year after protocol implementation. And now the measures on the bottom are different. These are the evidence-based measures. You can't see it. There's a dark blue bar that shows how many of the evidence-based measures we were collecting before the protocol was implemented, like none. And then the light blue bar is something like 80 or 90 patients the year after we started the protocol. And the green bar is 3 years after we started the protocol. So what this shows is that you can implement these evidence-based strategies in pediatric primary care with a high level of integrity, and you can have maintenance over time. It doesn't drop off. We also rescored all the measures and showed that the nurse that was scoring them all was scoring them with high level of accuracy. So we knew what was in the charts was accurate. This was actually published right before the Vanderbilt scales and the ADHD toolkit came out. And then it was like, oh, you don't have to do all that. You can just do this one measure. Still, an interesting study that I was actually able to publish in Pediatrics a year after we kind of got all the data together. And this was kind of another aha moment for me. It was like, wow, so instead of just helping this one patient, we came up with a process that's probably, since it's based on the evidence, better for 90 patients a year without me having to touch them, right? And now that since we did this with this study with enough integrity, we're able to put it in a journal that like lots of pediatricians read. So now we're actually maybe influencing practices all over the place. Like, that's kind of cool. And so I always like to show this picture next of myself with teams on my head, because really it takes a team, not just on a patient-by-patient basis, but a team to innovate and figure out how to make things work. And I've been impressed by that my whole career. So what I want to do today is talk to you about how what I just described, that story, translates to clinical innovation and using a new kind of science called implementation science, and how implementation science can be sort of accessible to people who are really clinical people, not full-time researchers, and allow them to do kind of what I just described in this little opening story. I'm going to describe why we need implementation science, what it is, give you an example, and then talk about implementation outcomes a little bit. So I like to think about science as having developed in the way that you see this bridge has developed. It's not finished. Or maybe it was at one time. But let's just say, for the sake of this metaphor, that this bridge is sort of an unfinished bridge. And what we have on the far left, where the bridge meets the land, is a pretty good infrastructure, a bunch of methods and journals that help us digest type 1 research. When we do basic research, we have methods and models. We have a pretty good set of questions to ask. We have journals that distribute that information. And then if we're translating that to some effective interventions, we know how to do that. We have randomized controlled trials and double-blind placebo-controlled trials, and we have all kinds of ways of doing good, rigorous tests of treatments. And all of that infrastructure takes you to right about here. What we don't have is a way to figure out how to take those things and make them work in real-world clinical environments. We don't actually have a science for how to do it, how to study it, and how to make sure that it gets uptake. And so what's happened is we've developed a situation where science is not getting to the streets. When I was in grad school, which I hate this part of the talk because I have to tell this whole specific timeline of my life, and you figure out how old I am. But I was in grad school in the early 90s, and I was taught parent-child interaction therapy as an evidence-based treatment. At that time, it had enough randomized controlled trials and big enough trials and robust enough findings that my field considered PCIT to be a gold standard evidence-based treatment. I learned it in grad school. It wasn't a tentative thing. It was like, this is the treatment. And that was, let's say, 92, 93, 94. I came to ETSU in 2006, and it wasn't until somewhere around 2008, 2009 that one of my colleagues, Dr. John Paul Abner, who was also trained in PCIT, approached Frontier Mental Health and started training Frontier Mental Health, community mental health providers in how to do PCIT. So 92 to approximately 2010, it's 18 years. And that treatment is finally making it to rural Appalachia, if you want to call us that, but we're not even that rural, right? That's too long. That treatment works. And in the meantime, I'm here in 2006 getting phone calls from Southwest Virginia of kids with major behavior problems that have been playing in sand with somebody in a community mental health center for 36 sessions. Not an evidence-based treatment. Why are they doing that? Does that make sense to you guys? Super frustrating. Makes me crazy. And so we have siloed research. It's very good research. It's doing good things. I'm super proud of the research that's coming out of my field. I'm sure you're proud of the research that's coming out of your field, but it's not making it to practice. Maybe you're familiar with one of our NIH mechanisms called an R01. It's like when you get an R01 as a researcher, you're considered like you've made it. You can just quit after that thing is done because that's the big ticket grant from NIH. 33 of those are funded, and these are $1 million plus grants. We get about one of them that turns into something that's truly usable and gets uptake in the real world. The other 32 are like academic exercises. Part of it is that there's no infrastructure reaching the far shore. And who's on the far shore? That's where all the schools are, and the primary care clinics, and the people who are kind of day in and day out grinding out patient care. And we don't have that stakeholder input. It's just a disconnect. And if we want to impact public health, if we want to see a big change population-wide, like I do for kids with behavior problems, for example, effectiveness is not good enough. Translating basic science into effective treatments is not good enough. We also need reach, and we need a science for how to study reach. And just think about immunizations if you want an example from the medical side. We know this stuff works, right? The problem is, how do we get everyone to do it? Or how do we get it to places and countries that have all kinds of implementation problems? Here's another kind of clue as to what the problem is. They got researchers, a whole bunch of them, and asked them, of the methods you use to disseminate your research findings, which do you think has the greatest impact on public health or medical practice and policy? So researchers are being asked, where are the hot spots for disseminating your findings? And this is what researchers said. They ranked. Then they went ahead and asked actual practitioners, and this is what they said. So where researchers think that they should be putting their findings is not where practitioners are looking. And just another example of the lack of infrastructure and lack of connection between these two worlds. And so the Institute of Medicine, otherwise known as the National Academy of Medicine now, talks about this learning healthcare system and the problem with that far left circle being our science. When it gets translated into the evidence base, which is your guidelines and your kind of review articles and some of the things that you might have an easier time reading than the original studies, a bunch of information is lost. When it gets translated from evidence to actual care and then to the patient experience, there's more drop-off. There's more that gets lost between the science and the care itself. And I would argue that, and I'm not the first person to argue this, that the patient experience and the care doesn't get back translated to the science. So people who are in research settings are not even asking fully informed questions or developing treatments that are fully informed based on what you all are seeing boots on the ground every day. Does that make sense? It's a one-way street, and it doesn't make it all the way across because we don't really know how to get it there. So there's this whole new type 2 research coming out now that we call dissemination and implementation science. And even though the figure depicts this bridge as completely missing from the edge of the bridge to the land, we actually do have some structures in place, and that's what I'm going to be talking about a little bit today. I like this quote. I don't know where it came from. If you want more research-based practice, in other words, if you want to do things that are science-based in your day-to-day practice, if you want an evidence-based decision to be made, then you've really got to do more practice-based research. Because much of what's known in the research right now doesn't translate to what you do on a day-to-day basis, so you're not using it. Does that make sense? Okay. So what is implementation science? Well, implementation very basically is introducing new practices or changes in a way that gains traction and follow through in the real world. And the science is just the study of that. How do we introduce things so that they actually happen? It's very hard. And I'll tell you one way that you don't do it is you don't give a lecture on it. So I'm doing a terrible job right now. However, there are a few people in this room who have worked with me on implementation science-like projects that have a better understanding for how it works because it's actually been experienced. But we now know that delivering a lecture on motivational interviewing does not translate to any kind of implementation in the real world. And so we really have to be very thoughtful because implementation is hard. So what are some characteristics of good implementation science? One is looking at stakeholders. So if I'm going to make this work in this clinic, who has to be involved in the decision-making process about the protocol? Who understands this, how it's going to interface with the front desk? Who understands what the nurses are dealing with and how we're going to translate it through the nursing part of the visit? Who understands how we're going to get paid for this? How it's going to be in the EHR? Who's going to be making decisions and in what order? All of those people have to be involved in the decision-making process, and they have to really feel like they are able to weigh in. We like to engage transdisciplinary teams because we know that if you silo everything in pediatrics and you don't involve, say, public health or behavioral health or other groups, you lose some richness and spread of the data and results. We like to incorporate novel partners so that research is not so academic-y as it once was. An example of a novel partner that I've used in the past is marketing, to make what I'm doing a little bit more interesting or engaging for patients, for providers, for other people. Does that make sense? Innovation and methodology, and then really kind of moving faster. Let's take some risks and hopefully get more rewards. And I'll talk more about methods in just a minute. And then always thinking, if we're going to try this and it works, can we scale it up? Or is it going to be impossible to scale up? We just recently trialed a complex patient visit in one of our clinics that was super labor intensive. And it was very informative, and I'm glad we did it. But we quickly thought, you know what? We can't do this for all of our complex patients. It took us half a day. And we don't have that kind of time. So we had to figure out a more efficient strategy before we scale it up. So always thinking like, how sustainable is this? Can it be done everywhere? What are we doing here? What's the long game? Challenges. The first one is getting people to stop doing things that are bad practice. And I don't really think exnovating is a word, but somebody said it once and I kind of liked it. The idea is getting people to de-implement sandbox therapy, which I mentioned earlier, or whatever they're doing that's not an evidence-based treatment. Another challenge is trying to get rapid and practical results, but have them have enough integrity that the data are generalizable. So if you're too fast and you don't have enough subjects or you don't have good enough data, it starts to become less meaningful for anyone else to look at. Need for new methods, because randomized controlled trials are too hard. They take too long. They're too impracticable for you all if you're in the clinics to be doing. So trying to come up with new ways to do things, making best bets on technology, like, hey, let's try this new app. And by the time you've trialed it, that app is gone and there's another app out there that's better or whatever. And so constantly trying to figure out how you're going to use technology. That comes up with EHR all the time. Well, we could build this in the EHR, but I hear we're getting a new one, right? Do we want to spend time on that now or make a better bet and wait later? And then this is my favorite one, fidelity versus adaptation. This comes up a lot in behavioral health interventions, but it's true for lots of things. So I know there's a behavioral health intervention for parent training, but it's a 12-session intervention, and each session takes an hour. That is not going to translate well if I'm trying to implement it in primary care. So can I do this thing in a half hour? Like the whole 12-session thing? Like what's important? Can I take it down to 3 sessions? Which core components do I save? How much do I worry about having fidelity to the evidence-based intervention and deploying it exactly as the evidence base shows it works, versus how much do I adapt it so that I can try something new in this setting and see if I can get it implemented. So this field of implementation science has all kinds of infrastructure, even though, again, the bridge looked like it was dead. It actually does have things. There are 61 D&I models out there to look at of how to do good implementation and do good implementation research. It does have journals that have methods and new studies coming out. There are training programs you can go to. There are annual conferences that feature D&I research. There's funding through a variety of resources that are just for implementation studies or dissemination studies. And increasingly, there's more policy infrastructure. And this is just a little editorial note. I just think this is very interesting. You know, the newest and latest and greatest from a policy perspective for all of us is trying to impact the triple aim, trying to improve population health, trying to improve patient experience, and decrease cost. And there's all these kinds of new ways of doing that coming out. There's a field called health services research. There are growing programs that help you do program evaluation or quality improvement. I'm thinking about like AAP has the FIT program, for example, which is a great program that helps you do a good quality improvement initiative in your clinics. There's PCORI, and then there's this other area called pragmatic research. And all of these models and methods play well to that policy scenario. So on the one hand, you may want to become engaged in implementation science because it's the kind of research that you can do if you want to be a clinical innovator. And I didn't go through all the reasons why you should want to be a clinical innovator, but I will at the end, because you do want to be a clinical innovator. If you're going to be a clinical innovator, then why not gather some good data and publish it and help other people out? Like it's kind of a, like help the world kind of thing. But you also may want to do implementation science because you're getting pressure to collect data to show quality and value in your services, just to get paid or just to get PCMH designation or for whatever reason. Does that make sense? So there's all kinds of like forces at work right now that put clinicians in primary care and other healthcare settings in kind of an optimized place to make a contribution. And I would say that there's an imperative that clinicians make a contribution because that stupid bridge is not going to build itself. And what we have right now is lots of academic people working from the constructed side of the bridge, adding bits and pieces to try to reach the shore. But they're not very well informed on what you do. And if you don't help and build back, then it's going to be a crappy bridge. I don't know what else to say. Like we've got to pitch in from our end and be like, hey, here's a brick. This is what we're finding. This is what it's like over here. Those kinds of studies have, I think, incredible value right now in the literature. So I'm not even going to talk about healthcare. Who would want to do that? I'm going to give you an example of a project that we've been doing in pediatrics and show you how, oh, poor Dr. Wood's been raising his hand. I didn't know that. Do you have him? No, you don't know what I'm talking about? Is he watching me? Yeah, Dr. Wood, if you're watching me, I got your text. I just don't know what to do about it. Can people see me somewhere? Are they watching me?
They should be.
Hi, everyone that's watching me. Yeah, text Karen your question. And apparently we're not on the technology. Text Karen. So what I want to do is walk you through one process that we're engaged in at ETSU Pediatrics that is a nice, like sort of rolled out example of how you might engage in implementation science in the real world. So the goal of this group was to identify a strategy for screening for and responding to social determinants of health in patients and families in pediatric primary care. So, you know, okay, raise your hand if you've heard about social determinants of health. Okay, good. So this is like a new thing, right? Like it's a good thing. We know now that patients' health is significantly impacted by the environments where they play and live and work, not just by their health condition, right? And you can address their health condition so well and so effectively, but if they're going back to an environment that's unsafe, unhealthy, if they don't have the resources they need to access the aspects to healthy living that really are required for them to get better, then they're not going to get better. So this team was like, how can we do a good job of figuring out how to improve people's social health environments and add that into our kind of complement of services that we offer here in pediatrics. So we used a process called champion teams to implement kind of a quality improvement process. And what that meant in this case was 8 30 to 45-minute meetings over about 6 months. Now think about that for a minute. That's really just a little over 1 meeting per month for 30 to 45 minutes. Does that sound unreasonable to you? No, it's not unreasonable. And it wouldn't have taken us 8 months. It was just that we timed it poorly. So we were ready to implement and roll it out to the whole clinic right when the new residents were coming on. So we actually had a little pause button for a couple months there. We would have been ready in 6. I'm sorry, 6 months was long. We would have been ready in 4. We used a very handy plan, do, study, act worksheet that allowed us to keep track of action items, assign action items. We kind of did like an iterative process where we'd come back together. How did those things go? We used data to make decisions. So we piloted a version of a brief screener, got up data on 300 patients and looked at it. This is all before the whole clinic had to get involved, right? We asked stakeholders around the clinic what they thought about the screener. Our pediatrician representative, you can see the picture here. So Dr. J and Karen Scazzino were on the team. They would talk to people about it, get information about it. Debbie Tebow worked with social work students and kind of vetted this process so that it was a very well thought out process. We were able to launch this thing and then have a couple of follow-up meetings. The champion team process is roughly organized using an implementation science framework called EPIS, which stands for Exploration, Preparation, Implementation, and Sustainment. And we're in the sustainment phase of the team care screener right now. But our champion teams were really like, the first meeting was what kinds of social determinant screeners are out there? Let's look at all of them. Do we get paid for any of these things? What's our capacity to implement another screener? That's exploration. Then we started preparing by developing the measure and piloting it and looking at the process and vetting the process. Then we implemented it and now we're in sustainment. Does that make sense to you guys? Now there's a much more elaborated description of this model elsewhere, but it gives you a sense of how implementation science can give you an evidence-based strategy for going forward. Now when I go to publish this thing, I'm not just writing, well, I don't know, we sat down and we were just like, I don't know, what do you think? I don't know, what do you think? How about we do it on Wednesday? Okay. And that's how a lot of developmental projects sound when they're written up. These kind of very descriptive, like, oh, I don't know, we were just exploring this process. Now you can like hook everything you've done into a framework that's well vetted and accepted by the scientific community that's standing on that far side of the bridge. So we have this measure. This is the measure itself. And just to show like our early dissemination process, we were able to put this into 3 different poster presentations that were presented, one at a student forum And you see the orange names represent students and residents who got a chance to participate, which is another benefit of champion teams and doing kind of this sort of quality improvement work within learning environments. And then the second presentation at the AAP meeting, and then the third one this past fall at the Collaborative Family Healthcare Association meeting. So this is just a really cool part of what happens when you do a quality sort of implementation science-driven improvement process or innovation process in your clinic. You now have some data, and it's well organized, and it sort of makes sense, and you can put it on a poster or put it into a presentation, and you can go to a national meeting, and you can stand there and have other people come up to you and be like, hey, we're doing something like that too, and get ideas about how to improve it, get ideas about how to change it, and kind of interact with the scientific community a little bit about what you're doing, and the clinical community as well. This is just some data that just show you kind of how it turned out. So about 12% of patients identify one social health need on that screener. And then if you look at those patients, 442 patients, you can see the kinds of needs they identify, mostly financial, transportation, and mood. And we have a little protocol set up where social work, when those things are high, goes in and meets with the family and does a follow-up measure. When we presented at AAP, we presented the social work intervention, which is this thing that's called a something map. What's it called? Eco map. There you go. Thank God you're here, and you're here. You were right there. You were on your toes. Very good. So, you know, these different aspects can present at a conference. Poster's a nice format because it's very much a creative innovator sort of format, get some ideas. I want to spend just a minute talking about the difference between patient outcomes and implementation outcomes and talk about where this project should go next to make a contribution, like kind of true implementation science style. So this is from Proctor et al., who did a really nice job of talking about all different kinds of outcomes that you can look at in any study. And the yellow box, client outcomes, are what most people think of when they think about doing research. Like, nothing matters unless we show that the patient got better. That's really kind of the deal, that their functioning improved and their symptoms went down. Their problematic symptoms went down. And most studies kind of hone in on that yellow box. That box is really where a lot of our effectiveness and efficacy trials are focused. Implementation science outcomes are really more focused on the blue box. But just to play this out, if we were doing the teen care screener and we wanted to know if it was actually helping people, then we would ask, did they like it? Did it help them make future appointments? Did it improve their overall health? We could find some health indicators and study them. A good one would be maybe the PHQ-9. Are they less depressed? And try to figure that out. Obviously, if they have better transportation and more food, then maybe their overall health is improved in some way, and we could look at that. And I'm not arguing that we should never do that, but a lot of the things that we're trying to implement in primary care or in any setting already have that study done. We already have the data from some great academic full-time researcher who had an R01 who did that somewhere else under really crazy stringent conditions that will never work in our clinic, but we can take what they did, think about fidelity versus adaptation, and implement it here, and that's kind of what we sort of did with this screener. So let's not talk about service outcomes today for ease. Let's focus on an implementation outcome study. This is really more consistent with implementation science. Now we're asking different questions than what a traditional study that you might think of would ask. Now we're asking, did the providers adopt the screener and referral? In other words, did our providers actually hand it out? And did patients fill it out? And did they collect it? Did they enter it into the EHR? Do we have it? And what was the reach of those services to the identified patients? Like, if we have this many patients who have social health needs, how many of them actually were touched by this program, got resources? And then the last question, can this be sustained? Is this something that was really fun, but it's so super time consuming, and since we don't get paid for these screeners, we can't do it anymore? So what we're doing now that we've been running the Teen Care Screener for almost 2 years, it'll be 2 years this summer, is we're starting to think about that blue box. And that's where the paper is going to be. It's going to be about the feasibility of actually implementing this measure in a real world setting. So just to put them side by side, on the left are the aims that were in the blue box, and on the right are the outcomes. So if one of the aims is to evaluate the provider's adoption of the measure, then maybe our outcome shows that the Teen Care Screener was completed by 91% of all parents attending an annual well visit with their child. That'd be good adoption of the measure. I would feel great about that result. And we have shown that result with many of the screeners that we've implemented using the Champion Teen process based on implementation science. Another aim might be what the reach, to evaluate the reach of the screener, and the outcome might be the social work team provided resources to 75% of those who indicated at least one yes. So we actually reached 75% of all the patients who were identified as having a concern. And lastly, to evaluate the cost of the intervention. I haven't thought much about this, but one thing we could do over the next 6 months is randomly sample 100 patients and how long our interactions with them are when they score at least one yes, and see what that time looks like, because time equals money, right? So it would be a way of evaluating sort of the cost to our clinic. You guys with me? Does that all make sense? It's a little bit of a different way to think about things. Well, I think I did ultimately make the case for the value of being a clinician innovator earlier. The point being that you have an opportunity to contribute to science, that you have the opportunity to keep up with all of the things that are being sort of put on our plates by payers and PCMH and other policy initiatives. But I would argue that many clinicians practice day to day and come up against barriers to practicing in ways that are fully consistent with their personal and professional values. I would argue that that happens pretty regularly. Anybody agree with that statement, that you're practicing and something happens with a patient and you're like, oh, not again? Because this is one where there's really nothing you can do. Your hands are tied, at least in the way that you do things in your clinic, and you're not able to do the extra thing for this patient that you wish you could do and that you would do if you could be the sort of full person that you want to be in your professional life. And if you can develop this clinician innovator side of you, there's always going to be that sort of self-definition and also increasingly skill set around, like, you know what, this is bothering me. This is like month 4 where I'm turning people away because of X, or they're not getting into mental health services because of Y, or we don't know if they have a positive screener or not because of blah, blah, blah. I want to do something different. Now, implementation science strategies are giving you evidence-based ways to make systematic changes. And if you practice those skills, you get better at them. And then ultimately, some ways to translate some findings backwards on the bridge, which, as I said earlier, I think has value as well. I will say, per this cartoon, that it's not easy. Requires a lot of grit. Because, like most things, do fail the first time. So you have to figure out, another way to go around. And so persistence is super important. But that's another talk for another day. Any questions? All right, I made science fun though, right? Yeah.
You did. I do have a question.
Yeah.
So like you said, it is hard and change is hard. So in all the times that you've done this, do you have any ideas or strategies for us to kind of cheerlead, if you will? Like, how do you make people adopt what you want to do? How do you garner enthusiasm? How do you how do you get them to be on board with whatever you want to do?
Yeah. Some of it is championing a cause, right? So you've got to be a bit of a politician. Some of it is looking for how your interests align with other needs in the clinic, right? So if it turns out what you want is consistent with what we need for PCMH or something that we can actually make a little more money if we do it this way, or it would be better for some other reason. So you kind of have to look at, how do I sell this idea? How do I market it in my clinic? And I think those are really important skills, for everyone to learn.
For the stakes.
Yeah, just try to figure out what the stakes are. And sometimes it requires making modifications to your idea so that it fits better with somebody else's dream, and then you kind of combine things and it's not quite 100% of what you wanted, but you get somewhere. But I don't know if that answers your question, but that would be my answer.
And then if you encounter negativity, what do you do to kind of swim past it?
That's such a great question. I said politician earlier, and there's a little irony in there, but I actually went to an implementation science conference in September, and I heard entire presentations on research around being a practice facilitator. And it's an emerging field. There are actually people now who are training to become practice facilitators. One of the most startling and interesting findings that I heard about in the facilitator presentations, I went to a lot of them because I kind of think that just sort of describes a lot of the work I've done over the last several years. And that is going into a practice, sometimes with an idea, sometimes taking ideas and making them come to fruition. And wouldn't it be nice if you had like a full-time facilitator, right? That's like coming. This idea of somebody that's a champion for causes and has the skills to do that. So the most interesting presentation I went to was can you guess what's the most important skill that a facilitator needs to have? And a bunch of things come to you, like good communication skills, or good critical thinking skills, or organization, or an understanding of how healthcare systems work, knowledge, latent knowledge, blah, blah, blah. And it turns out that it's relationship building. That is the number one skill.
That is interesting. I would have thought good listener, maybe.
Yeah, well, which comes with relationship building. But it really is like, I feel like as a person who plays the role of facilitator, walking in with a lot of energy, walking in with a very much a can-do attitude, and encountering negativity as not so much a challenge or a barrier, but I always see it as, well, this is good data. This person doesn't want to do this. There's a reason for that. What's behind that? Because that's going to help me unlock this thing even better when I know. And I'd rather have someone transparently be negative with me and say it's not going to work, or I don't want to do it right out of the gate, because then we have known problems out there. So it's really great when people are negative. It's an opportunity to learn. So
that's a great way of looking at it.
Yeah, yeah. That was a longer answer than I thought I had for that one. Anyway, you guys are awesome. Have a good afternoon. Thanks.